Welcome to Chapter 15, Abnormal Psychology, Disorders and Treatments. This is the final chapter. This is the final lecture of the semester. Congratulations for making it this far. You guys rock immeasurably. Moving on to slide 2. In covering this chapter, we're going to go over three main topics. One is defining what abnormal behavior is. The second is explaining technically what disorder categories are. And then finally, what treatment is available for the disorders. Slide 3. What is abnormal? Well, here's the fun part about anything quote-unquote abnormal. It allows you to question what is considered normal, or the social norms that shape what we consider normal behavior and thoughts. The following examples were taken from the Great Course series of lectures, credit where credit is due. So, what if somebody started slamming their shoe on the wall? Is that abnormal? Probably. Is it diagnosable? Maybe. Well, what if somebody walked around naked under a trench coat while they went about their regular errands? Is that abnormal? Yeah. Is it diagnosable? Likely. What if I came to class wearing a dress? Is that abnormal? Is that diagnosable? Where do we draw the line? How do we know abnormal behavior when we see it? When we see abnormal behavior, how abnormal does it have to be for a diagnosis? How about a criminal charge? Well, let's leave the legal talk to the criminal justice educators and focus on the psychological diagnoses. Slide 4. What is a mental disorder? Well, the American Psychiatric Association defines a mental disorder as a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. That seems a reasonable definition, but it's not always easy to practice. Who decides whether someone has a clinically significant disturbance? Do we let people themselves decide? Do we always trust a psychiatrist or psychologist to decide? What if therapists disagree with one another? Well, let's look at 4 standards of determining whether or not an abnormal way of acting, thinking, or feeling is diagnosable as a mental disorder, starting with the statistical standard. In the class where we talked about intelligence and intelligence tests, we talked about normal distribution of scores and how this normal distribution is represented by a bell curve. The center portion of the bell curve is where a majority of data points accumulate, with scores falling outside of the center categorized as variance from the norm, in units called standard deviations. By definition, then, the scores on the tails of this distribution represent a statistical deviance from a norm. Abnormal? Question mark. Slide 6. As a review, the low end of the bell curve of IQ test scores is used to diagnose intellectual disability, or ID, with categories of ID beginning with IQ scores at or below 70. But if tails represent abnormal deviation from the norm, what can be said about the other side of the bell curve? Scores above 140 are just as abnormal as scores below 70. But one is the criteria for a potential mental disorder diagnosis, while the other is not. Using a non-IQ example, if we looked at the normal distribution of performance on, let's say, cycling, Lance Armstrong, or any other competitive cycling athlete, would be considered abnormal. But does that also mean that he should be diagnosed based on that abnormality? This method of determining what is abnormal based on normal distribution is called the statistical standard, and it works for some situations, but not all the time. While we do make room for gifted, abnormal individuals at the top end of the bell curve, not every behavior, emotion, or thought process falls along a normal distribution. The moral standard. Another common standard for determining what is or isn't abnormal is asking whether the behavior, thought, or emotion violates a moral norm rather than a statistical norm. Using the moral standard on the examples I gave earlier, the example of being naked under a trench coat stands out as violating our moral standards and therefore contributes to it being perceived as abnormal. A downside of using a moral standard for abnormality is that moral standards change. For example, regardless of how accepted homosexuality is in today's society, it was at one time the consensus that homosexuality was immoral. In fact, it was considered abnormal enough to be diagnosable up until 1973. That's 2 years after I was born. Humans are weird. The harm standard. Of utmost concern for the person whose behaviors seem abnormal enough for psychological diagnosis is the risk of harm to themselves or others. What is the chance that harm will be done to themselves or others is the question professionals are always keeping on their radar when dealing with clients and assessments. If someone seems at risk for harm or harming, an intervention may help reduce that risk. The unhappy standard. Lastly, regardless of whether the situation fits in a normal distribution or violates a moral norm, and as long as no one's at risk to cause harm to self or others, we have to look at whether the situation affects someone's quality of life by decreasing their happiness. It is still worth looking at how someone feels, even if it doesn't map onto any real-world problems. Whether it does or not could help address any cognitive or emotional processes that could inform the diagnosis, though. These 4 standards are used in a mix and match way because we need a variety of techniques and standards for determining what is abnormal. While you can reduce errors, you can't get rid of them. And addressing the complexities of human experience requires a diversity of approaches. We humans are a messy, sloppy lot. It's not always clear which events are abnormal or why. And even if we agree that an event is abnormal, the criteria for it to be diagnosed depends on a combination of 1, whether it fits a normal distribution can be considered an outlier, 2, whether it violates moral standards, 3, whether it puts someone at risk for harm or others at risk for harm, and 4, whether it actually bothers the person in question. Slide 7. Classification systems. But wait, we aren't just diagnosed as abnormal. There is a whole classification system getting updated every few years that lays out both general classes and subclasses of specific diagnoses of psychological disorders. Here's a quick history of classifying mental illness. Anthropologists, these are people who study human history and prehistory, find skulls with holes drilled into them for the assumed reason of releasing evil spirits. This provides evidence for a long history of humans attempting to both classify and treat abnormal behavior thought to be caused by demons. The ancient Greeks explained behavior in terms of 4 fluids. An excess of blood caused a sanguine, courageous, and loving personality. An excess of phlegm caused a phlegmatic or calm personality, right? We went over this. So anytime that you have a cold and you have too much phlegm, you're not sick, you're just calm. And too much yellow bile can make somebody choleric or easily angered, and too much black bile made somebody melancholic or sad. In Chinese philosophy, personality cycles through 5 stages or elements, just as the seasons do. An excessive response could cause too much fear, anger, and so forth. Also, Freud and his followers used a handful of vague diagnoses to help patients with hysteria or neuroses in the 19th century. All of these approaches were attempts to classify behaviors that were considered abnormal or worthy of treating. Slide 8. The DSM. Bump, bump, bum. Then, in the 20th century, the American Psychological Association decided that they would start official classification of mental disorders after World War II began to deal with the influx of infantry who had served in the war and needed treatment for the issues that they were dealing with as a consequence of their service experience. The result was the Diagnostic and Statistical Manual, or DSM, first published in 1952. And, as mentioned earlier, the DSM gets edited and updated as we learn more about human behavior. While the first edition of the DSM utilized psychoanalytic or Freudian theory to provide a theoretical context for the classifications, this Freudian approach was removed between the second edition in 1968 and the third edition in 1980 in an attempt to become a-theoretical or without a theory. Over time, with more research being done, the system has become more reliable and valid, mostly due to the criteria for classifying mental disorders. The latest edition of the Diagnostic and Statistical Manual of Disorders, the DSM-5, lists possible diagnoses and the criteria for identifying each of them. These criteria have nothing to do with demons, fluids, the seasons, or elements. The standard view today is that abnormal psychology results from a combination of biological, psychological, and social influences, as reflected in the APA's definition for a mental disorder as a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. This is referred to as the biopsychosocial model. The biological roots of abnormal behavior include genetic factors, infectious disease, poor nutrition, inadequate sleep, drugs, or other influences on brain functioning. The psychological component includes reactions to stressful events. For example, people who are physically or sexually abused in childhood are more likely than others to develop psychological problems in adulthood. Also, behavior must be understood in a social or cultural context. Behavior that is considered acceptable in one society might be labeled abnormal in another. For example, loud wailing at a funeral is expected in some societies, but not in others. We learn from our culture how to behave normally. We also learn some of the options for behaving abnormally. Current reasons for classification. Our current healthcare system is born out of a medical model which begins with a diagnosis based on a classification of symptoms, then moves forward with a treatment based on that classification diagnosis. Psychology works within this medical model because the first psychologists, like Freud, were medical doctors practicing psychiatry, a medical practice. Also, with the explosion of the field, clinical psychologists after World War II having a classification system was a clerical solution to deal with the onslaught of returning soldiers with mental issues related to having served in the war. Lastly, in more recent times and with the ubiquity of medical insurance as a way to offset medical costs, there are insurance reasons that contribute to our current use of classifications. Put simply, insurance companies dictate which treatment options are and are not available to a client based on their diagnosis of a classified disorder. That is, they're only willing to pay for certain things. Those certain things better be backed up with a diagnosis. Slide 9. Here is a table of psychological disorders as listed in the DSM-5. Some criticisms. Slide 10. The DSM has helped standardize psychiatric diagnoses so that psychologists use terms like depression, schizophrenia, and so forth in more consistent ways than they would otherwise. However, this approach assumes that every disorder fits into one category or another, and that each troubled person can receive a single, unambiguous diagnosis. In fact, many troubled people fit several diagnoses partly, and none of them perfectly. If you're suffering from depression, mania, anxiety, substance abuse, conduct disorder, obsessive-compulsive disorder, or schizophrenia, the chances are better than 50-50 that you are suffering from one or more of the others also, at least to a mild degree. You might fit mainly into one diagnosis now, but a different one later. Furthermore, different disorders have many overlapping causes. The genes that increase the risk of any one disorder also increase the risk of other disorders. Highly stressful experiences, such as the sudden death of a loved one, can trigger the onset of depression, anxiety, or schizophrenia. Even when therapists agree on a single diagnosis, the diagnosis doesn't reliably point the way to a treatment. Antidepressant drugs sometimes help people with disorders other than depression, and antipsychotic drugs sometimes help relieve non-psychotic disorders. This is the use of medications off-label. Potential solutions. Many psychologists who are dissatisfied with the DSM approach would prefer to rate each client's problems along several dimensions, instead of trying to give each person one label. For example, instead of a single diagnosis, a therapist might use ratings like the one shown on this slide. A further criticism is that the DSM labels too many conditions as mental illnesses. If you seek help to increase your enjoyment of sex, you have sexual interest arousal disorder or hypoactive sexual desire disorder. A woman with premenstrual distress gets a diagnosis of premenstrual dysphoric disorder. If you get at least 7 hours of sleep per night, but still feel sleepy during the day, and you have trouble feeling fully awake after a sudden awakening, you have hypersomnolence disorder. The list goes on, with hundreds of other possibilities. Surveys have found that almost half of all people in the United States qualify for at least one DSM diagnosis of mental illness at some time in their life. Slide 11. Story time. Another critique of using a classification system is that once diagnosed, the label that you're diagnosed with can affect both the way you see yourself and behave, but if that label is known to others, it can taint their perceptions of you and the way they see you and the way you behave. Even professional mental health workers. Think about that. If your mental health professional sees a label applied to you via diagnosis, they may miss cues that don't line up with that diagnosis while focusing on the ones that do. This is a form of what's known as confirmation bias. We had talked about this. It's the tendency in all humans to gravitate towards information that confirms what they already believe. We would expect that through training and experience, mental health professionals would be less prone to this bias as applied to their area of expertise. Well, there's a study that explores this. This study, led by David Rosenhan and his group of researchers individually, they admitted themselves into psychiatric wards in the 1970s. And then they tried to get out by exposing the hoax and saying, haha, we were kidding, we don't belong in here, right? And pointing out that they didn't have a mental diagnosis. You can imagine how this turned out. More specifically, when the individuals were brought in for their intake evaluation, they practiced the symptoms and responses that would land them a schizophrenia diagnosis based on the symptoms of schizophrenia outlined in the DSM at that time. Once admitted with a diagnosis of schizophrenia, they stopped using the practiced symptoms and responses, admitted that they faked them, and tried to get out of the psychiatric hospital. On average, it took 1 month before the researchers were let out of the psychiatric hospital. And when they were, the mental health screeners doing the exit evaluation still diagnosed them as schizophrenic, but in remission. Remission is just a different phrase of saying no longer symptomatic. They no longer are presenting symptoms. They're still schizophrenic. They're just not presenting schizophrenic symptoms. They're in remission, right? Which means that they don't believe what they were being told. They don't believe that they really weren't schizophrenic. They're still holding on to the idea that they are. They're just in remission. That is a deep cut. Even after they were told the whole plot, the mental health professionals, they still believed that. Instead of believing the researcher that they were actually void of any schizophrenic symptoms other than the ones that they practiced just to get in, they maintained that they were still schizophrenic. the mental health professionals. It's just that the symptoms aren't presenting right now. I love this experiment. Here's the take-home point. Labels, like diagnostic labels, can and do shape perception. Slide 12. Here is a list again of the psychological disorders according to the DSM-5. We're going to be covering some of these. Not all of them, but some of them. Slide 13. Let's go over some specific disorders. Slide 14. We've gone over some of these disorders in previous lectures. The eating disorders we went over when we were talking about motivations, hunger motivations, sleep-wake disorders, when we were talking about circadian rhythms, neurocognitive disorders, we were talking about memory loss and Alzheimer's. So we're not going to repeat the ones that we've already gone over, but that still leaves a lot. So move on to slide 15. Here's just a nice little infographic that shows some common disorders. So I'm just going to cover like 3 or 4 of the top according to, this is the year 2021. Reporting year 2021. But for this year, considering that we are still in the middle of a pandemic, I think there's a couple few diagnoses that we should be going over that you might be hearing about a lot in the news or experiencing yourself. So let's do this. Slide 16. Disorders with excessive anxiety. Let's start with, what is anxiety? According to Medline Plus, anxiety is a feeling of fear, dread, and uneasiness. And people experience this in different situations, at different levels, for different reasons. Some people just have a generalized feeling of anxiety. This is diagnosed as a generalized anxiety disorder, or GAD, where the person experiences excessive anxiety much of the day, even when the actual dangers are low in their environment. Panic disorders are also considered anxiety disorders. They're characterized by episodes of disabling anxiety, high heart rate, and rapid breathing. Several studies have shown a genetic contribution to panic disorders, although no single gene has a strong influence. Examples would be many people with a panic disorder known as agoraphobia. These are people with an excessive fear of open and public spaces. There's also social phobia, which is a severe avoidance of other people and a fear of doing anything in public. The usual treatment focuses on teaching the patient to control their breathing, learning to relax, and understanding the situations that trigger their anxiety. Being able to control their environment, control the stress, also helps. Slide 17. We mentioned agoraphobia in the last slide. Let's talk a little bit more about phobias. Phobias are just avoidance behaviors that are highly resistant to extinction. For example, if you believe that Friday the 13th is dangerous, you're cautious on that day. If nothing goes wrong, you decide that your caution was successful. If a misfortune happens, it confirms your belief that Friday the 13th is dangerous. As long as you continue an avoidance behavior, you never learn whether or not it is useful. Again, this falls into the category of confirmation bias. Phobias interfere with normal living. Many people develop phobias through traumatic experiences, but some also learn their phobias by watching others. When we were talking about behaviorism, we covered a way to deal with phobias through a process called systematic desensitization. So this is pretty much the process of extinction as it applies to simple learning, used to make a situation that causes anxiety become less fearful. Slide 18. Obsessive compulsive disorders. People with OCD have distressing thoughts or impulses. Many also perform repetitive behaviors. So let's break down what the difference is between an obsession versus a compulsion. Obsessions are thought process, and they generally lead to compulsions, which are behaviors. For example, somebody obsessed about dirt and disease develops a compulsion of continually cleaning and washing. Hand washing behavior would be an example of this. The most common compulsions are cleaning and checking. Checking would be, did I turn the stove off? Did I turn the lights off? Right? Another common one is counting one's steps, counting one's objects, or counting almost anything, or having to do things a specific number of times. Hoarding is also another common compulsion. Slide 19. Let's talk a little bit about substance dependence, addiction. People who find it difficult or impossible to stop using a substance are said to be dependent on or addicted to it. Almost all addictive drugs increase the release of dopamine in a small brain area called the nucleus accumbens, which is apparently critical for attention and reinforcement. However, beware of assuming that the release of dopamine causes addiction. For example, compulsive gambling and video game playing have much in common with drug addictions. After they've become addictive, they release dopamine, but it would be misleading to say that they became addictive because they released dopamine. It's hard to put limits on what can or cannot be an addictive substance. Some people show addictions to gambling or video games, which are not substances at all. Some have managed to abuse water. The motives for initial use of alcohol or other drugs differ from those of addiction. People drink alcohol for pleasure, to relax, or to suppress social anxieties. An addiction is more insistent. Addicted drug users get much less pleasure than they used to, but they continue to want the drug anyway. Why do addictive behaviors continue with such intensity? One reason is to escape unpleasant feelings. Abstaining from a drug leads to withdrawal symptoms. Withdrawal symptoms for prolonged alcoholism include sweating, nausea, sleeplessness, and sometimes hallucinations and seizures. With opiate drugs, withdrawal symptoms include anxiety, restlessness, vomiting, diarrhea, and sweating. Consistent cigarette smokers experience unpleasant mood when they abstain. Also, someone who takes a drug to relieve withdrawal symptoms learns its power to relieve distress and then begins using it to relieve other kinds of displeasure. People who have quit drugs often relapse during periods of financial or social difficulties. Slide 20. Depression. People with depression find little interest or pleasure in life. Sadness is characteristic of depression, but lack of happiness is even more characteristic. About 20% of U.S. adults are depressed at some time in life. Depression occurs in episodes. Typically, people have an episode of depression that lasts a few months, less commonly years, and then they recover. However, the depression may return. Later episodes tend to be briefer but more frequent. Typically, an intensely stressful event such as a divorce or a death of a close loved one triggers the first episode of depression, but later episodes may occur with less provocation. In a related condition, seasonal affective disorder, people repeatedly become depressed during a particular season of the year. The most effective treatment for seasonal affective disorder is exposure to a bright light for a few hours each day, assuming the bright light is full spectrum UV. Slide 21. The role of genetics with regards to depression is far from clear. Although studies of twins and relatives of patients with depression indicate a moderate degree of heritability, extensive research on the chromosomes of thousands of people fail to identify a gene with a major effect. Perhaps many uncommon genes are capable of leading to depression, or perhaps the explanation lies with epigenetics instead of chromosomal changes. Most people with depression have relatives with depression, and also relatives with other problems, such as substance abuse, antisocial personality disorder, attention deficit disorder, bulimia, etc. Many people recover from depression and then later develop anxiety disorders, maybe substance abuse disorders, or even eating disorders. In other words, the genes or other factors that predispose to depression increase vulnerability to many disorders, not just depression. Slide 22. And that's where I'm going to leave it with the disorders. So let's move on to, we've already talked a little bit about treatments, but let's talk about the idea of treatment of mental disorders more specifically. Slide 23. If you remember from the lectures at the beginning of the semester, Sigmund Freud exerted quite a bit of influence on psychology by beginning so many areas that are still robust fields of psychology today. His psychoanalytic theory of personality differentiated normal from abnormal behavior, explained the causes for the abnormal behavior, and provided a form of treatment that addressed the cause of that abnormal behavior. Before we get back into Freud on our way to exploring different types of psychotherapy, let's take a quick look at how psychotherapy has changed since the 1950s. Slide 24. Psychotherapy is a treatment of a psychological disorder by methods that include a personal relationship between a trained therapist and a client. Treatment of a mental illness has changed greatly since the mid-1900s, and Table 15.4 summarizes these changes. In the mid-1900s, people seeking psychotherapy paid for it themselves, whereas today, most people rely on insurance. In the 1950s, psychiatrists conducted almost all psychotherapy. Remember, psychiatrists are medical doctors in a way that clinical psychologists are not. And today, clinical psychologists and other specialists provide treatment. Today's therapists also use a variety of empirically supported treatments with much less reliance on Freudian methods. Therapists try to achieve good results in just a few sessions when possible, instead of the prolonged monthly, yearly process that the psychoanalytic Freudian approach took. Today's therapists provide diagnoses for more disorders and define their diagnoses more carefully. I think that's one of the more salient differences. Slide 25. So let's begin talking about 4 different kinds of psychotherapy. Let's start with Freud and his psychodynamic therapies. This should be a review. So, psychodynamic therapies attempt to understand conflicting impulses, including some that the individual does not consciously recognize. Psychoanalysts try to uncover the unconscious reasons behind self-defeating behaviors. To bring the unconscious to consciousness, they rely on techniques like free association, dream analysis, projective methods, and transference. Psychodynamic therapies are meant to break through the protective mechanism preventing access to the unconscious so that therapists can get an inkling of what's going on to build a model of what the unconscious mind is doing in their client so that they can help them with their current symptoms. Slide 26. There's also behavior therapists. Behavior therapists, we talked about a little bit ago, assume that abnormal behavior is learned and can be unlearned. They identify the behavior that needs to be changed, such as fear or bad habit, or phobia is the example we used earlier. And then they set about changing it through reinforcement and other principles of learning. Unlike psychoanalysts, they're more interested in changing behaviors than in understanding their hidden meanings. Behavior therapists set very specific goals for changing a client's behavior and use learning techniques to help clients achieve those goals. Setting a clear goal enables a therapist to judge whether the therapy is succeeding. If the client shows no improvement, the therapist changes the procedure. Behavior therapy is remarkably effective at dealing with phobias, as we talked about earlier, using the technique of systematic desensitization. Moving on to cognitive therapists identify distressing thoughts, such as, people don't like me, or my enemies are out to get me. And they try to get clients to replace defeatist thinking with more favorable views of themselves and the world. Many therapists combine features of behavior therapy and cognitive therapy, attempting to change people's behaviors by altering how they interpret the situation. And this all works because, as noted in this slide, cognitive behavior therapy sees a connection between 3 things: cognitions, which are thoughts, emotions, which are feelings, and actions, which are behaviors. If you want to change one, you need to change one of the other two or both of the other two. And more appropriately, you can't change one without affecting the other two. Haha. Slide 27. Cognitive therapies focus on changing people's thoughts and encouraging a more active life. According to Aaron T. Beck, a pioneer in cognitive therapy, right over the bridge at University of Pennsylvania, depressed people are guided by thoughts that he calls the negative cognitive triad of depression. I am deprived or defeated. The world is full of obstacles. The future is devoid of hope. Right? So this is a negative view of the past, negative view of the present, and negative view of the future. People who have these automatic thoughts interpret ambiguous situations to their own disadvantage. Therapists try to overcome these thoughts and get clients to reinterpret events in a more positive way. A therapist might invite the client to regard the negative thoughts as charges by a prosecuting attorney and then act as the defense attorney to produce counterarguments. Cognitive therapists also encourage people to become more active, to take part in more activities that might bring pleasure or a sense of accomplishment. Slide 28. Humanistic psychology, yes. So humanistic psychologists believe that people can decide deliberately what kind of person to be. According to humanistic therapists, once people are freed from a feeling of rejection or failure, they can solve their own problems. In Carl Rogers' version of humanistic therapy, person-centered therapy, also known as non-directive or client-centered therapy, the therapist listens to the client with total acceptance and unconditional positive regard. We've talked about this before. Most of the time, the therapist paraphrases and clarifies what the client has said, conveying the message, I'm trying to understand the experience from your point of view. The therapist strives to be genuine, empathic, and caring, seldom, if ever, offering interpretation or advice. So how do we know how good these therapies are? Well, to evaluate psychotherapy, we can't simply compare people who did or did not choose to enter therapy. Those who sought help might differ from the others in the severity of their problems or their motivation for improvement. In the best studies, people who contact a clinic are randomly assigned to receive therapy at once or wait for therapy later. A few months later, the investigators evaluate people's improvement, often by their answers to standardized questionnaires. Most experiments have included only a moderate number of people. To draw a conclusion, researchers use a method called meta-analysis. We've also talked about this before. This takes the results of many experiments, weighing each one in proportion to the number of participants, and then it determines the overall average effect. So, according to a meta-analysis that pooled the results of 475 experiments, the average person in therapy showed greater improvement than 80% of similar people who did not receive therapy. For a variety of disorders related to anxiety or depression, all the mainstream types of therapy appeared nearly equally in effectiveness. Later research qualified the statement somewhat. For several types of disorders, cognitive therapy or cognitive behavioral therapy produces a slightly greater reduction of the target symptoms, such as anxiety. But all the common types of treatment are roughly equal for less specific goals, such as overall quality of life. Slide 30. And here's a table that just demonstrates some differences in the four kinds of therapies. None of this particular slide is going to be on a quiz or exam, but it's interesting to see. Slide 31. At the beginning of the semester, I asked for you to conjure an image of a prototypical psychologist, and I admitted that for most people, the Freudian therapist is usually what comes to people's minds. Accompanying this prototype of clinical psychology are questions like, tell me about your childhood, or what was your relationship like with your mother? Because of Freud's influence in psychology, and since his form of psychotherapy is based on focusing on past events, like those of childhood, some people feel that all effective psychotherapies force you to confront the root causes of your problems in childhood. This idea is reinforced by popular media, as we see therapists in movies and television asking clients to probe their past. But as we've made mention time and time again, Freudian thinking does not reign supreme in the world of clinical psychology anymore. Instead, therapies have been developed that are much more forward-thinking, like the four that we went over just now. Instead of exploring how your childhood got you to where you are with all of your current problems and baggage, Gestalt, humanistic, and cognitive behavioral therapies are more interested in what your goals are moving forward and how any current obstacles that you have can be removed or circumvented for you or by you to achieve your future goals. Here it comes, people. Here's the pep talk, end of the semester. Especially in today's healthcare system, especially considering right now our circumstances, the amount of time needed to learn about someone's history and process all the ins and outs of that history is beyond any insurance company's willingness to pay. And today's model of therapy aims at getting the best effects as soon as possible, and learning the complete history of somebody is just prohibitive to that goal. I bring this up because I still think going to see a therapist is stigmatized in society in a way that I think is bullshit. If you break your foot, you see a foot specialist. If you have tooth pain, you see a dentist. If you have a problem with the way that you feel, think, or behave, there's a specialist for that. And there's no shame in that game. If you or anyone you know wants or needs therapy, but you're afraid that it'll involve the process of confronting childhood problems or any bullshit like that, and therefore you don't even want to try to seek it, I'm here to tell you that it's okay. You can go to therapy. You can work on your concerns, and you don't have to spend 8 years going through your childhood. This happens all the time. For those of you that are interested, for those of you that need help getting through the last bit of this semester, getting through this part of your life, there are student services available at Rutgers. The link on this slide is the one that you should follow. If you can, there are websites now dedicated to providing mental health services. Those links are also available. The take-home point here is that nobody should suffer if you're having a problem with your quality of life, with the way that you're thinking, with the way that you're feeling, with the way that you're behaving. There are people out there trained to and willing to help you. Slide 32. What about the future of psychotherapy and attempts to prevent mental disorders? Psychologists, especially community psychologists, seek to help people change their environment to promote mental health. Prevention is avoiding a disorder before they start. Prevention takes several forms. A universal problem targets everyone, such as an anti-smoking campaign or abolition of lead-based paints and leaded gasoline. A selective program includes only people at risk, such as people with a family history of some disorder. An indicated program identifies people in the early stages of a disorder and tries to stop it. Effective prevention programs need careful testing. Many interventions that sound reasonable don't work. For example, prolonged discussions of a stressful experience shortly after the event are more likely to cause than prevent post-traumatic stress disorder. Another example is scared straight interventions. They tend to increase, not decrease, criminal behavior. The best programs of prevention give participants active practice at specific behaviors, such as resisting peer pressure to risky behaviors. They build up step by step from simple skills to more complex ones, and they work with people at appropriate times in their lives. Examples of effective prevention programs include the following. Ban toxins. The sale of lead-based paint was banned because children who eat flakes this is a great sentence. The sale of lead-based paint has been banned because children who eat flakes of lead-based paint Sustained brain damage. I think that every band that I have been in has had at least one member who ate leaded paint flakes. Education to pregnant women about prenatal care. The use of alcohol or other drugs during pregnancy damages the brain of the fetus, and bacterial and viral infections during pregnancy can impair fetal brain development. You can outlaw smoking in public places and educate people about the risks of smoking. Improvements in physical health improve psychological well-being. Help people get jobs. People who lose their jobs lose self-esteem and increase their risk of depression and substance abuse. Summer jobs for low-income teenagers decrease their probability of violent crime, not only during the summer, but also long after. Neighborhood involvement. Low-income people who move from a crime-ridden neighborhood to a less distressed neighborhood experience long-term benefits in mental health. And lastly, prevent bullying in school. Children who are frequently bullied have an increased risk of anxiety, depression, and other distress throughout life. All these are ways to prevent mental health disorders. Slide 33. Congratulations, people. We have finished the last lecture of the last chapter of the last module of the last week of classes. How many more times can I say last? Last. You all rock immeasurably. I recommend that you do the quiz for this chapter, although it is not required. Spend your time studying, getting your study participation credits in, and getting ready to kick ass on the final exam. Have an awesome summer.